speaking about cardiovascular findings in RDEB. And just give us a minute, we're going to pull up his presentation. Would you like to use the pointer?
It's okay. I can just click. I don't think I'll. Is there a pointer on here?
There is a pointer on there.
Okay, great.
Just start at the beginning.
Yeah, thank you.
Is that the beginning?
Yes, ma'am.
Okay.
Where's the pointer?
It's right here.
Oh, perfect. Very good. All right. Thank you for the opportunity to speak, and thanks to the organizers for allowing us to participate. So we have a large program in Cincinnati, as you know, and over the last few years, we've actually been recognizing that perhaps some of the cardiac disease that's been described in EB probably really hasn't adequately characterized the scope of the potential disease. So I'm going to talk a little bit about that today, and this is meant to be interactive. At the end, I'll answer whatever questions, and I'm glad to hang around and talk if that's of interest. So as you all know and you've heard, that multiple organ systems can be involved, but one that perhaps isn't as highlighted frequently is the cardiovascular system, and I'm going to spend some time talking about that today. And as you've heard and as you appreciate just from everyday life, the findings can be very broad, very heterogeneous. And so I'm going to try and give you a full scope of what we look for from a cardiac perspective, and then what do we try and do about it. So when we talk about heart disease and we talk about kids and young adults, there are usually sort of two large buckets that you might want to think about that we would consider. One is this idea of congenital heart disease, meaning people that are born with holes in the heart that shouldn't be there, valves that don't work well, some of the plumbing is abnormal. That is not commonly seen in the EB population, and so those are things that you're born with that sometimes may require a surgical intervention or some sort of a catheter-based intervention. But the other thing that we pay attention to is how does the heart actually work? So how does it squeeze and how does it relax? So this idea of myopathy or heart muscle disease, and that's something we're going to spend some time on today. The other thing is about the vasculature. So the heart is great, but if it doesn't pump blood through the tubes and get it to the organ systems that are essential, it actually doesn't really matter. And so as you all know, the tubes that leave the heart that pump oxygenated blood out to the body are called arteries, and the major artery that leaves the heart is called the aorta. And I'm going to show you some pictures of that today. But we actually have found some novel findings in our RDEB population that actually suggest that this vascular structure may be abnormal. And it sort of makes sense based on what you've been hearing about collagen, is that this is a connective tissue-rich structure. And so abnormalities in connective tissue may lead to abnormalities in this tube. And I'll show you some pictures so this makes more sense. So when we talk about heart disease, specifically about heart muscle disease, usually the way that we would screen patients is by using what's called an echocardiogram, or an ultrasound of the heart. And what that really does, one, it tells us that make sure that all the valves and the chambers and the plumbing, everything is correct, everything is connected correctly. But the other piece is it gives us an opportunity to look about how the heart functions, and we can also see the pictures of the vessels that leave the heart, which I'll show you some examples of in just a few minutes. And when we talk about this heart muscle disease, we rely on echocardiography very extensively. And it's just like an ultrasound that you would do anywhere else in the body. It's a little more extensive. We use some fancier techniques to make sure we can see blood flow and those sorts of things. But it's actually hugely available. Every hospital in the United States has access to ultrasound technology. And most everyone does these echocardiograms, which is specifically just an echo target, or an ultrasound targeted at the heart. And the important thing some of the takeaways that I hope you glean from this lecture is simply that when someone has the potential for heart muscle disease, which is what we're talking about here, is that the structural piece, like I was talking about valves and those sorts of things, you're either born with that or you're not. We talk about heart muscle disease, that's something that can develop over time. So we have to keep paying attention. And so one of the big messages I hope that you take away is that simply because if you've ever seen a cardiologist, if you've ever had an ultrasound of the heart of your child, and you were told it was normal, that doesn't mean that that's a lifelong sort of okay. this heart muscle business can change over time. And we actually aren't smart enough to know when it's going to change. So the importance of surveillance is actually a pretty big key for what we do. So when we talk about heart muscle disease, there are 5 types that we talk about that are genetically triggered or mediated. And the top 2 are the ones that I'm going to talk about to you today. The first is dilated cardiomyopathy, and I'll show you some examples of what I mean by that. And the second is left ventricular non-compaction, which is relatively rare, and we actually reported the first case in an EB patient from Cincinnati. So I'll show you this idea of dilated cardiomyopathy. And this is actually, when we talk about people who have heart failure, probably you know someone or someone in your family has heart failure, so meaning their heart muscle doesn't work very well. Maybe they've had a heart attack, maybe they have diabetes, maybe they have high blood pressure. This is the kind of heart disease that they have. And we're talking about, if you look on the left, you see the heart is relatively normal in size. This heart on the right, the cartoon, is actually big and globular, so you can see the left side of the heart has become enlarged. And an easy way to envision this is simply, if you look at this normal heart, it almost looks like a football. It's conical is what we would say. So it's sort of pointy. The top part is relatively narrow. So like if you took a football in half, that's kind of what a normal heart looks like from a left ventricular perspective. A heart that looks like this is more like a basketball, so it becomes big and globular, and it doesn't squeeze very well. And that's a problem, because this is what a normal heart would look like. So this is what an echocardiogram is. So when we take an ultrasound picture of the heart, this is what it would look like. So this is the pumping chamber that we care about on your bottom right, okay? So this is normal. Now keep that in your mind. This is what a bad heart looks like. This is what dilated cardiomyopathy looks like. So see that, what I was talking about, it's sort of big, globular, looks like a basketball. It really does look like a basketball. You can appreciate that this isn't squeezing very well. So sometimes people try and get up and exert themselves. They can't mount enough of a blood flow out to their body to actually keep up with the oxygen demands that they have. And that's why they become symptomatic. They can't walk very far. They become fatigued. They may pass out. There are different things that are associated with this, but this is what we're trying to avoid. And this is what we're talking about with dilated cardiomyopathy. And so we know that this dilated sort of heart muscle disease, or what we say DCM, has been characterized in patients with EB in the past. And there are some relatively large reports in 2010. Dr. Lucky was a part of this report, but this was a multi-center study that specifically looked at about 15 patients. So they called multiple centers across North America and said, do you have any patients that you've seen heart muscle disease in? And they said, yeah, we have. We've seen about 15 patients. And the majority of those were recessive dystrophic patients, and then about 13% were junctional patients. But the important thing was that they did see the heart muscle wasn't squeezing very well, but the good news was for most patients is that the degree was relatively mild. It wasn't that serious sort of looking ultrasound that I showed you a picture of. But they know that it was there, and a lot of these patients ultimately needed therapy, and unfortunately a few of these patients actually succumbed to having heart disease, or what we would say heart failure, because the heart muscle dysfunction was so profound. And so we started wondering about this, and we obviously have a large experience, and this is something that we do on a daily basis, looking at the way the heart functions and how that affects patients. And so we looked back at our cohort of about almost 225 patients, and we wanted to see who all had an ultrasound of the heart. Well, you can imagine from what you've been hearing and over the last few years, doing cardiac interrogation hasn't been a routine part of EB care for the most part, right? So part of my job, I hope today, is to try and alter that thought process a little bit. But looking at this, we did have a few patients that had ultrasounds, and we found about 60 or so that had echocardiograms. And we haven't reported this. This is actually under review, but this will be one of the largest reports ever. It actually will be the largest report ever, specifically looking for novel cardiovascular findings in EB. And so we found about 7 in 45 that actually had those heart squeeze problems that we were talking about, which is very important. But the other part was that idea of the basketball shape, this where the heart becomes globular and dilated. We actually noticed that in quite a few patients as well. And the important thing is that, one, these were all in our recessive dystrophic patients, okay? And the important thing we thought as well is that in the non-RDEB population that we have, we actually didn't find any cardiac dysfunction or any evidence of cardiac dilation, which we find to be very encouraging. But the important thing is that we found heart muscle disease that was there. And the important thing, what we do in medicine, we can diagnose things all day long, but if we don't have a therapy or something that we can offer, sometimes our hands are tied. It's important to know, but if we can't do anything about it, you have to sometimes step back and wonder, what's the utility? We actually have wonderful treatments for these sorts of things. And I can tell you the majority of the patients that we've actually seen that actually have evidence of heart muscle dysfunction that we've started on therapy, they've actually gotten better. So their heart muscle function has actually gotten better. The size has gotten smaller, and their squeeze has gotten stronger, which we think is very encouraging. And I'm going to talk to you more about what those therapies are in just a few minutes. So this is this other idea of heart muscle disease, and this is called left ventricular non-compaction, and this was a report that we had just a couple of years ago. And I'm going to show you some pictures of normal again and abnormal, but the things I want you to focus on are what this arrow is pointing to. You see these big sort of things sticking out into the chamber here. So this is that pumping chamber again. And these are called trabeculations. And they're kind of like fingers if you look at them on an ultrasound test. And the way I explain them to patients is if you ever go into a cave, you see things sticking up off of the floor, these stalagmites, right? That's what these kind of these look like. They're sort of these big sort of muscular projections that go into the chamber of the heart. And you can see them here a little more clearly on this cartoon, but they're these big crypts that are in the heart muscle. So normally in heart muscle, this should all be filled in with muscle. There shouldn't be holes or caves that go in down to the body of the left ventricle, mostly because, one, that should be muscle. It should be squeezing, right? So if it's not squeezing, you could potentially compromise your ability to deliver blood out to the body. But the other piece is that down here, blood can get down into these little holes and can actually clot. So if you ever put blood and you put it in a tube, you sit there and leave it for a few minutes and it doesn't squeeze, doesn't move. The natural tendency of blood is to clot. And what happens is if blood clots down in here and it actually flips off and goes out to the body, that's the nidus for a stroke. Okay? So those could go to the brain, could actually go to the kidney, the foot, the liver, wherever. That's a problem because that's going to occlude oxygen delivery to the brain or whatever organ that is. And so that's a big deal. So we actually want to know if patients have these sorts of crypts or caves because we would potentially want to do something about it. And so this is sort of an embryologic phenomenon, and I won't get too heavy into why we think that it happens because we don't fully understand it at this point. But the simple answer is that there's some arrest in the way that the heart muscle comes together. Whereas most heart muscle starts with these finger-like things, they actually fold together about 8-10 weeks of gestation, come together and make a nice smooth surface. So the inside of the left ventricle should be kind of like this floor. You run your hand across, it's relatively smooth. But for whatever reason, some patients, this sort of what we call compaction doesn't happen, and that's where the name comes from, non-compaction. And we use ultrasound technology because it's pretty easy. You saw a nice picture there, and we can get really good images of what's going on. And the fact that every hospital has this technology, like I was telling you about, and it's been around for quite a few years now that people feel comfortable in the ability to interpret these things. But we also have some fancier techniques that sometimes we'll use to diagnose both types of heart disease, actually. Sometimes we'll use MRI. And MRIs are great because it gives us this beautiful characterization of the heart tissue. And the analogy I use for patients is if you ever watch an ultrasound, and if it's an echo like the one I was showing you, it's sort of like watching black and white TV on an antenna, okay? That's kind of what it looks like, which is fine. You see something beating, and sometimes you get good signals, sometimes you get bad signals, and that's exactly the way echo is. MRI is kind of like the high-definition TV version of that sort of picture, and I'm going to show you what I'm talking about in just a second. And what it does actually gives us the ability to look at the muscle in a very discrete way. When you saw that, it was sort of black, white, gray, the echocardiogram. We're talking about with the heart muscles that we can actually see areas that are muscle, areas that are scar, areas that are swelling or edema. All those sorts of things can be done with an MRI. So this is what the echocardiogram looks like. Once again, that's that black and white. And these are actually very good pictures. This is normal, okay? This is what that LV&C I was telling you about looks like. You don't need to be a cardiologist to tell those two things are different, right? Obviously different. So you see those big tracks that go all the way down. Blood's going down into those things and hopefully coming out. Sometimes it doesn't. And if blood gets trapped down here, it could potentially clot. And then when it does flip off, it's actually what's called an embolus. okay? So it's important for us to diagnose this kind of heart disease. And this is that with where it's not beating, where it's a still frame, and you can appreciate these big dropouts. This should all be heart muscle, but instead you've got these big gaps. They're sort of like pillars down there. So that was the black and white. This is the MRI picture, okay? So this is a still frame picture. You can see, so this is that pumping chamber we were talking about. You can see how thick it is, and you see those caverns going all the way down. So these big black dropout pictures of where muscle should be, and it's not, okay? And so this is the high definition version of what we're trying to do. And the other advantage for what we do in MRI, but unfortunately we don't have as much advantage to it in our EB population, is the idea of gadolinium, so we can give a contrast agent and actually see if the heart muscle has been damaged or scarred in some way. Unfortunately, this requires an IV. So we don't always pursue that. Sometimes we do. If we're getting intravenous access for some other reason, we'll try and also do a cardiac MRI at the same time. And it gives us a lot of information because, one, we get these wonderful pictures, but also I can tell patients you have normal heart muscle or you have evidence of scar. And that's a big deal. Scar, if you think about it, is kind of like wood, like this lectern here. So scar doesn't squeeze, right? So that's one big problem. Two is that it's a nidus for unusual heart rhythms like ventricular tachycardia, so what people get shocked for on TV. So those are things that we want to know about because, one, it might modify our therapy. But two, if we don't see it there, we think patients really are set up well to do fantastically well long term. And so when we talk about the LVNC, we talk about this idea of the emboli that I was explaining, the little blood clots, the unusual heart rhythms that I was explaining, and then the ability to be predisposed to sudden deaths because of those unusual heart rhythms. But the most common thing we worry about is the heart failure piece, and I'm going to explain what I mean what exactly is heart failure in just a second. So when we talk about heart failure, really all we're talking about is that the heart either can't relax well enough or it can't squeeze well enough to keep up with the demands of the body, okay? Some people, that's if they try and go up 10 flights of stairs. Some people, that's when they're sitting in a chair. And so there's a very broad range of symptomatology that I'll explain to you in just a second. And so I take care of both kids and adults. I'm an adult cardiologist and pediatric cardiologist. So when we talk about this syndrome in a 70-year-old, those are the people you see that they're very swollen, so they may have an extra 40 pounds of fluid on board. They have to sleep setting up, those sorts of things. Those are classic symptoms of heart failure. In kids, the typical symptoms are none. So if I'm relying on just questioning a patient, said, I want to do a history on you and say, tell me about how you feel, chances are I'm not going to find anything that would point me in the direction of that patient having heart disease. Okay? So that's why we rely on these imaging technologies to give us a lot of insight. This is something that's a little busy, so I apologize, but really all it says is that simply that we have patients over here that have genetic predispositions or other diseases that predispose them to developing heart muscle disease, or some patients it's exposures, for example, people that have received chemotherapy. But all patients that have high blood pressure, all patients that have diabetes, and then we're talking about any genetic triggers that may lead to heart disease. You start over here on the left side of the page. You can potentially move further and further over to the right side of the page if your heart muscle starts to become weak over time. And with that, when we start seeing weakening of the heart muscle, we talk about the institution of medical therapies. And I'm going to show you what I'm talking about specifically in just a minute, where we have people over here that they are predisposed compared to the general population of having a problem with their cardiac function. And then as you move over here, they have problems with their cardiac function, but they don't feel it. You move over here, they have problems with their cardiac function and they feel it. And then over here, they have problems with their cardiac function and they feel it all the time, okay? That's the severity scale that we're talking about. And with that, each step comes increasing severity of intervention, from going from oral medical therapies to intravenous medical therapies to pacemakers to defibrillators to mechanical hearts. So all these things play into how we manage patients and what we're going to try and do over time. And this is just a very high-level view of what we're trying to accomplish with these medical therapies, is that we have some reason for the heart muscle not to work very well. In this situation, that's going to be a genetic trigger typically. There have been thoughts about things like selenium, carnitine deficiencies, all those sorts of things playing into heart muscle disease. But whatever the trigger, we know the heart muscle isn't behaving the way that we want it to. And it ultimately leads to this vicious cycle of where we get changes in the genes and their expression, where we get unfavorable hormonal balances in the body. What we're trying to do with the medical therapies is to mitigate this bad cycle so it doesn't keep going around and around and potentially leading to symptoms or even potentially death. And so when we talk about these sorts of damages, this is exactly that. So this is the normal heart, and I was telling you over here is the basketball heart that we're trying to avoid, right? So what we would love to do is if we see someone here and they're moving in this direction, we would love to capture them here in the middle and not over here, right? So that's the advantage of doing aggressive and sort of thoughtful longitudinal screening. But what we try and do with the medical therapies is if we get someone here or here, we're trying to take them back over here. So back to the left side. We're trying to go back to the normal if we possibly can. And the way that we do this is with medical therapies typically in the United States. And these are medicines that guaranteed you know someone, or you may be on a class of these medicines. Everyone in this room probably knows someone or personally takes them. So ACE inhibitors, beta blockers, and diuretics. So ACE inhibitors are things like enalapril, lisinopril, ramipril, benazepril. And they all have commercial names, but guaranteed you know someone on these therapies. Most of the time they're used for blood pressure, but we use them to help the heart muscle work better. And then the beta blockers, very similar, things like atenolol, propranolol, metoprolol, carvedilol. All those drugs are very commonly prescribed in the U.S., and we use them relatively effectively. Like I said, we've been very pleased with what we see in our patients in Cincinnati. We've actually seen improvement in some patients' normalization of how their heart muscle actually works. So when we talk about the heart muscle piece, I just feel strongly that careful attention to what we're looking for on an echocardiogram is important, but it can't just be one echo. It has to be multiple echocardiograms, okay? And then for some patients, we use MRIs because it just gives us better pictures. There are some patients, and that's going to be true of all of us, that just make better pictures with ultrasound than, some people it's very easy to get pictures with ultrasound. Some people it's very challenging. In those situations, we would think about using an MRI. And when we talk about treatment, it very much depends on what kind of heart muscle disease you're talking about and the severity of that disease. And like I say, we've been very fortunate that we've had good response with the therapies that we use. So in the last couple of minutes, I want to talk to you about the blood vessels that I was alluding to earlier. So we reported this patient who had those trabeculations, those stalagmites that were coming up off the floor of the left ventricle. But the other thing that we noticed was that the tube leaving the heart, the aorta, was actually enlarged compared to what we consider normal. And we have normal measurements for a range of what people should fall into. And I'm going to show you some pictures of what I'm talking about in just a second. So the aorta is the main vessel that leaves the heart, takes all the blood to the body. And it's important because disease of that vessel can be a real problem. If you've heard of anyone who ever has an aneurysm, so an aneurysm in their chest, this is the tube or the structure that we're talking about in reference. So if you look up on the left, and on your left is what we would consider a normal aorta. So this is where the blood is leaving the heart. It goes up into this tube and around, and there are a bunch of branches that come off of this thing like a highway. And that's how you get blood out to the head, the neck, down to the legs, all that kind of stuff. Over here is where this tube has become abnormally dilated. So this is a dilation of this particular segment called the aortic root, okay? And don't get too worried about the anatomy, but you can tell very easily that those two things don't look alike, right? And the question is, well, why do we care? So what, it's big. The problem is that this can lead to a couple of problems. One thing is that it can make the valve that it's connected to become insufficient. So the valve can become leaky because this tube is dilating. But the other thing is what we actually care about most importantly is the risk of a thing called a dissection. So the inside of this tube can get a tear in it, and it can actually tear, where you essentially bleed into the wall of this tube, and it can be very much a serious mortal event if it's something that's not treated very aggressively. So that's why we care. And this is the patient I was telling you about that we actually see where this tube was enlarged. So this is that pumping chamber that we've been paying attention to, and when that blood leaves, it goes into this aorta. And this is a dilated aortic root. It's not massively dilated, but it's obviously abnormal. And the reason that we cared is because we actually put this patient on a medical therapy directed at trying to control the rate of growth of that tube. And I'll explain what I mean in just a minute. So it prompted us to step back and think, well, no one's really paid much attention to this that we can appreciate in the EB population. And we actually found that nearly 20% of our recessive patients had dilation of that portion of the tube. No one's ever talked about this before. And it's a pretty big deal because it's potentially something, one, that we can treat, but two, it could be a potential source of morbidity and mortality. So we've tried to pay a lot of attention to this, and this is something that we're in the process of writing up right now. You need years and years of follow-up to know what these things actually mean, but it's something that we actually feel strongly about making an intervention on. So when we talk about this aorta business, we know that we have lots of treatments that can either slow the rate of growth, so this tube can potentially get bigger over time, just like kids grow over time. And these medical treatments can either slow the rate of growth, so it may be getting bigger. Let's just, you want to pick out a number and say it's getting a centimeter bigger every year or something like that. If we can control the rate of that growth where it's only getting half a centimeter bigger or a quarter of a centimeter bigger, that's an amazing intervention, because eventually it's going to get to a certain size. We would talk about having to do a surgery to replace that portion of the tube. And there are actually some cases where we can see this tube getting big. We put people on medical therapy and it actually gets smaller. It gets more appropriate to their somatic size, which is also very important. So the reason, like I said, that we care is because we don't want patients to have surgery. We don't want to have one of those tears or dissection, which are a pretty big deal. It's not something that you want to have to deal with. And so what that means is, just like with the heart muscle disease, you have to keep paying attention to the size of the tube. We do that with ultrasound technology. You can also do it with MRI, or you can do it with CAT scan technology, what's called an angiogram. So I just would once again urge everyone to keep in their mind that at least it's our opinion that cardiovascular disease has to be considered as a possibility, and it's something that needs to be thoughtfully managed and have adequate surveillance over time. Simply because these are diseases that could potentially cause problems, they can cause symptoms, and they could even potentially cause death. But probably the most important thing is we actually have medical therapies for them. So these are things that I treat every day and very easily can be detected, can be very easily managed. And like I said before, most of the treatment is defined by what the disease is and where do we catch it in the course of everything. This finding of the aortic disease, the dilation of the tube, I think is very important. And it gives us a lot of insights into why patients would have, with primarily dermatologic involvement, what is the real nidus for having vascular involvement? No one's ever described that. And it really does come back to these connective tissue links, which I think are hugely important. If you have access and you see these sorts of things, prompt your physician to refer you to a cardiologist who actually has special expertise in doing this. We do think that most of the time medical therapy is probably going to be warranted, and these medicines are very benign in our kids and adolescents. So I know no one likes taking medication, but the flip is they all come in liquid preps, and everyone seems to do reasonably well with them. And what we want to do with both the heart muscle disease and the vascular disease is avoid any kind of worsening and a potential need for a surgical intervention. So with it, I'll thank you for your time, and I'll answer any questions later. Thank you.
So you talked about the idea of ejection fraction and how those kind of play in on that, and at what point do you start to get worried?
So we didn't get too much into the terminology, but ejection fraction is what we refer to as the volume of blood that's ejected with each heartbeat. So if you think about your heart filling with a volume of blood, we would say, let's just make up 1,000 cc's. That's an easy number. However much blood is ejected with the squeeze part is what your ejection fraction is. So if you had ejected 700 cc's, you would say 700 cc's were ejected. We started with 1,000, so that's 70% of that volume. So your ejection fraction would be 70%. Normal ejection fractions are between 55 and 70. We start paying attention less than 55. Most people don't use ejection fractions. Most of the literature that has been written are based on shortening fractions, which are a little more rudimentary, and I won't go into too much detail. Ejection fraction is far superior in characterizing this heart muscle dysfunction, and that's what we use. Yes, ma'am.
What would you consider a reasonable sort of interval of screening for a patient?
It's a great question.
Who shows no clinical signs,
Yeah.
but as part of their, multidisciplinary care?
I'll tell you what we do for most patients that we think are at risk, especially patients that are still growing. Okay, if it's Dr. Farrell, I don't need to image him every year or something like that. But for people that are still growing, we think once a year is a pretty reasonable interval. For our patients that we actually see something of concern, we would probably image every 6 months. Definitely patients that we have on medical therapy, we would try and image every 6 months. Ma'am?
What ages are you actually seeing?
That's also a great question. Some of the reports have reported cardiac involvement less than 6 months of age. Our spectrum is quite diverse, actually. We've seen some patients that are young, so less than 5. We've seen some patients that don't have evidence of heart muscle dysfunction until mid-teens. And I can't say that we've seen anyone later than that that's had significant involvement, but it really underscores this idea of you don't know when things are going to change, and so I think screening is doing it in a regular way. And I do think back to this idea of how often would you see it. If we had a patient who got multiple echocardiograms, we felt confident we were seeing what we needed to see. Somewhere around 18, 20, 21 years of age, we would probably talk about spacing those visits out a little bit more. So maybe every 2 to 3 years would be reasonable. But we would also want to see those patients back quickly if symptoms change. So things like shortness of breath, chest pain, ever feeling dizzy. We always see patients if they ever pass out, simply because of the concern of these unusual heart rhythms that I was talking about. So we do try and individualize things, but I think that would at least be a general guideline for you. Ma'am? So talking about the chamber being enlarged? Yeah. Our view is one where, and we deal with this a lot actually, we'll see children and adolescents that come in and have heart muscle disease, and we treat them and they get better. And the first question the parents usually ask is, can we come off of the medications, right? Some people that don't get better, we would advocate lifelong therapy. That's just sort of that's something that I don't think most people would debate. But the real question is, if you get heart muscle that was abnormal, it goes back to normal in the face of medical therapy, is it okay to stop the medication? And in our view, we usually would say it's better to keep patients on the medication, simply because there was a reason the heart muscle got better, and it's not because of just hoping, wishing, whatever. We think it's probably because of the medical intervention. You definitely could be. Once again, we do try and individualize, and there are some families who we do stop medical therapy with the understanding that this could get worse again. The problem is when it gets worse is that oftentimes it's not as responsive to the medicine as it was the first go around. But the other thing is that, in those scenarios where patients want to come off medications, is that we image them like we were just talking about, or pay attention to them more frequently to make sure things aren't declining. But I think it's an individualized therapy. And some of it has to do, it's a very complicated answer about what the cause of the heart muscle dysfunction was, and I'd be happy to talk to you more about that. Well, so when we talk about heart muscle disease, the genetics aren't specific just to EB. There are multiple other genetic etiologies which could be shared by siblings that have nothing to do with EB. And happy to talk more about that. That's actually way more common, obviously, and that's a very common problem in the worldwide population. Yes?
My question is, how soon do you treat? Because my son had a normal echo in October.
Uh-huh. Right. Yeah, it's a good question. So I think everyone individualizes their approach. You have to recognize that medicines, we use them, we do very well with them, but it's still an added burden on the family, and there are potential toxicities related with medication. The classic indication to start medications are when the heart squeeze goes down. Some people do start it when the left ventricle starts to dilate, like you said, but if you look at the guidelines, they would suggest whenever that ejection fraction or the shortening fraction start dropping, that actually is what we would say is a class 1 indication to start the medication. We have started medicine on patients that do dilate because almost inevitably those patients that dilate, their heart muscle function is going to start going down. Okay. Yeah, it's a great question. So we're still trying to figure it out. There is absolutely no doubt that it is known that certain vitamin deficiencies can cause heart muscle disease, and the classic is vitamin B1. So that's well known. But it's also known that carnitine deficiency can result in heart muscle disease. Selenium can result in heart muscle disease. The majority of the patients that we deal with in our center are actually supplemented. They have levels monitored, those sorts of things. Dr. Lucky and her team are very good about doing that. But the question is I guess, are those levels and those therapeutic sort of targets that we're looking at, are those adequate for this population? Meaning, could it be involved with maybe we need higher doses, maybe we need super therapeutic? I don't think anyone actually knows the answer to that. We actually are pulling all of those data. I think our bigger question is, are there genetic possibilities that we can understand, genetic triggers, specific mutations that might give us insight into cardiovascular disease? But your question is absolutely a very thoughtful one, and that's something we're trying to figure out. Ma'am. It's a very good question. There's no doubt that the cardiovascular implications of potentially losing a lot of volume, so from a dehydration perspective, is important. There's no doubt that the ongoing inflammation that goes along with the skin disease can impact cardiac function, and you're absolutely right. What we think, though, is probably what we're seeing is actually a tissue-specific problem, so there's something actually within the heart that's not working well as in the aorta or the vasculature. But what you're talking about what we would consider a secondary cardiovascular effect. I definitely think that it can impact things. The biggest thing from my mind would be the inflammation. Sorry, I ran out.